Greetings, I'm the dentist. Welcome back to DENTAGENDA. This is Chapter 4, Orthodontics. This tutorial is about orthodontic assessment. These are the points we're going to discuss in this tutorial. In orthodontic treatment, you should always start with a pre-screening procedure. The purpose of this is to ensure the early detection and treatment of any abnormalities and to prepare the patient for any later treatments and influence the management of any teeth of poor prognosis. At every visit and once the secondary incisors have erupted and until the secondary dentition is fully established, keep the eruption sequence in mind and note the failure or delayed eruption for any teeth. Failure of tooth eruption over 6 months after the contralateral tooth has erupted should be alarming, and in that case, you need further investigations. Ask the child to close together and look for cross bites, reverse, or increased overjets. Consider the long-term prognosis of the sixes, as extraction of poor quality first permanent molars might be needed in some cases. From the age of 9 years and onward, and until the canines erupt, palpate for the canines and the buccal sulcus. A definite hollow and/or asymmetry warrants further investigations, as the canines might be impacted or palatally displaced. Gathering information. This procedure should be carried out in a logical sequence so that nothing is missed. Note who wants the treatment, is it the patient or the parent, and what for. Ask if the patient is willing to wear braces or not. Inquire about any previous extractions or orthodontic treatments that has been done. Check the medical history, of course, and assess the growth status. And finally, assess the suitability of the orthodontic treatment for this patient, including motivation, oral hygiene measures, and commitment. Moving on to the clinical examination, you should start with the extraoral examination and assessing the skeletal pattern of the patient. Check the facial form. Is it mesocephalic, brachycephalic, or dolichocephalic? Check the profile. Is it straight, convex, or concave? Check the anteroposterior relation of the two arches. If the maxilla is equal to the mandible, it means that the patient is in skeletal class 1. If the maxilla is larger than the mandible, means that the patient is skeletal class 2, and if the mandible is larger than the maxilla, the patient is skeletal class 3. Vertically, check for the lower face height. In a normally proportioned face, it will be equal to the middle facial third. And transversely, check the symmetry of the right and left two halves. Check the nasolabial and mentolabial sulci angles. Are they deep or shallow? Because that has a dental indication for the upper and lower anteriors. Also note the breathing pattern. Is it nasal or oral? Still in the extraoral examination, but now examining the soft tissues. Note how can the patient achieve lip competence. Is it with or without muscle activity? Check the position of the lower lip. how the patient can achieve an oral seal. Is it a lip-to-lip seal, which is normal, or lip-to-tongue, or by lip being drawn up behind the incisor or trapping the lips? Note the length of the upper lip, as it affects the amount of the incisor seen and the amount of gingival display upon smiling. Check the rest position of the mandible and note any displacement or deviation upon closure. Note the presence of any borofunctional habits like thumb or finger sucking, biting the nails, bruxism, and clenching the teeth. Moving on to the intraoral examination. Record the oral hygiene status of the patient. Is it bad, fair, good, or excellent? Note the gingival condition. Is it healthy or is it inflamed or recessed? The teeth presence. Is it a full set of teeth or if there is any missed or impacted teeth? Any teeth with poor prognosis that need to be treated or extracted? When you assess the lower labial segment, look for the following: the inclination of mandibular base, the crowding or spacing between the teeth, displaced teeth, angulation of lower canines. And assessing the labial segment, look for the inclination of the maxillary base, crowding or spacing, rotations, displaced teeth, the presence and the angulation of the upper canines. Crowding. If the crowding is less than 4 mm, it is considered mild. And if it ranges between 4 to 8 mm, it is considered moderate. And if the crowding is exceeding 8 mm, it is considered to be severe. Check the molar and the canine relationship. Is it class 1, 2, or 3? And note the presence of any cross bites. Measure the overjet in millimeters and measure the overbite. And note if it is increased or decreased, complete or incomplete. And finally, note the relation of the upper and lower midlines. The upper midline with the facial midline, are they coincident or not? And the upper and lower dental midlines, are they coincident or if there is any shifting? Just keep in mind that the overjet means the horizontal relation between upper and lower teeth, and the overbite is the vertical relation between the upper and lower teeth. Diagnostic records in orthodontic treatment are a necessity to facilitate the diagnosis and treatment planning. They allow you to measure the progress and the outcome of the treatment when you compare the before and afters. They act as medical legal record for your own safety, and they can be used in research work. Diagnostic records that can be used in orthodontic treatments include radiographs, whether a panorama or a lateral cephalometric, hand and wrist, periapicals, and others. Photographs, extra and intraorals, diagnostic casts or intraoral scans, and also facial scans. Radiographs in orthodontics. Orthopantomograms or panorama. You can use them to look for unerupted, missing, or displaced or supernumerary teeth. Also, you can detect any pathology and check the root morphology looking for plumed or pipette-shaped roots. Also, you can know the outline and status of the bone and condyles. Lateral cephalometric radiographs. It can be used to view the skull in the lateral view. It is indicated in the patients that has skeletal discrepancy or anteroposterior movement of the incisors is anticipated. The upper standard occlusal view can be used to identify the position of impacted canines, and also that can be done more accurately if you do a CBCT. Photographs in orthodontics. You should get familiar with using a professional camera, set up the settings, the flash, and also using the different tools that help you to take an intraoral photograph like occlusal mirrors, retractors, and contrasters. Photos should be of a good quality and in color, of course, and they should include intraoral and extraoral photographs. Study models or intraoral scans in orthodontics. They can be used to measure the arch length, which is the space available. Also to measure the mesiodistal widths of teeth and add them to each other to calculate the space required. Measure the overjet and overbite and to view the occlusion. Now to the creation of the problem list. These are the information that you gather and then you subdivide them into lists. The pathological problems include caries, perio or endo diseases, and impacted teeth. And the developmental problems. They include the patient's concerns, skeletal and anteroposterior problems, vertical and transverse discrepancies, alignment of upper and lower arches including crowding or spacing. The Index of Orthodontic Treatment Needs. IOTN stands for Index of Orthodontic Treatment Need. It was developed to quantify and standardize an individual patient's need for orthodontic treatment so that the potential benefits can be weighed against the possible disadvantages. The index consists of two components that we will discuss in details: health component and aesthetic component. The health component. The dental health component of Index of Orthodontic Treatment Need has 5 categories of treatment needs, ranging from little need to a very great need. A patient's grade is determined by recording the single worst feature of the malocclusion. That means that if 2 or more features of malocclusion give the same grade, then the scale tells you which one comes first. MOCDO acronym is helpful when assessing dental health component as it provides a hierarchy of severity. M stands for missing teeth, including congenitally missing teeth, ectopic and impacted teeth. O stands for overjet, including reverse overjet, which is underbite. C stands for crossbite. D stands for displacement, or the displacement of contact points. Tooth displacement was explained in details on how to manage it in previous tutorial about dental traumatic injuries. You can check it. And O stands for overbite, which can include deep or open bites. Now to the grades of the index that tells you the need for orthodontic treatment according to the severity of the case. Grade 1 means that the teeth are virtually perfect. Grade 2 means that there is minor irregularities including a slight overjet or open bite. Grade 3 means that there is greater irregularities, a greater overjet, open or deep bites, and bigger teeth displacement. Grade 4, when there is severe irregularities including a large overjet, large reverse overjet affecting speech, and large displacements. And grade 5 represents the extreme irregularities which need treatment, including impacted teeth, such as ectopic canines and severe hypodontia. Now to the aesthetic component of the Index of Orthodontic Treatment Need. The aesthetic component based on a series of 10 photographs of the labial aspect of different Class 1 or Class 2 malocclusions, which are ranked according to their attractiveness. Number 1 being the most attractive appearance, and number 10 is the least attractive appearance. A patient's score is determined by the photograph, which is deemed to have an equivalent degree of aesthetic impairment of the patient that you can match to the photos. Now explaining the grades in details. Grade 1 means there is no need for orthodontic treatment. There is extremely minor malocclusions, including displacement less than 1 mm. Grade 2 means there is little need for treatment, like in the following cases. Increased overjet from 3.6 to 6 mm with competent lips. Reverse overjet from 0.1 to 1 mm. Anterior or posterior crossbite with up to 1 mm discrepancy between retruded contact position and intercuspal position. Displacement of teeth from 1.1 to 2 mm. Anterior or posterior open bite from 1.1 to 2 mm. Increased overbite from 3.5 mm or more without the tooth contacting the opposing gingiva. Prenormal or post-normal occlusions with no other anomalies includes up to half a unit discrepancy. Grade 3, where there is a borderline need for treatment. You'll find that the cases are the same as in Grade 2, but the numbers are increased. Increased overjet from 3.5 mm to 6 mm or less with incompetent lips. Reverse overjet from 1 mm to 3.5 mm or less. Anterior or posterior crossbites with 1 mm to 2 mm or less discrepancy between retruded contact position and intercuspal position. Contact point displacement from 2 to equal to or less than 4 mm. Lateral or anterior open bite from 2 mm to 4 mm or less. Deep overbite with complete gingival or palatal tissue contact with no trauma. Grade 4, where there is a need for orthodontic treatment, like in the following cases. Less extensive hypodontia requiring pre-restorative orthodontics or orthodontic space closure to activate the need for a prosthesis. Increased overjet from 6 mm to 9 mm or less. Reverse overjet more than 3.5 mm with no masticatory or speech difficulties. Reverse overjet from 1 mm to less than 3.5 mm with recorded masticatory and speech difficulties. Anterior or posterior cross bites with greater than 2 mm discrepancy. Posterior lingual crossbite with no functional occlusal contact in one or both buccal segments. Severe contact point displacement more than 4 mm. Extreme lateral or anterior open bites more than 6 mm. Increased and complete overbite with gingival or palatal trauma. Partially erupted teeth, tipped and impacted against adjacent teeth, and the presence of supernumerary teeth. Grade 5, the absolute need for orthodontic treatment, includes impeded eruption of teeth, except for third molars, due to crowding, displacement, the presence of supernumerary teeth, retained deciduous teeth, or any pathological cause. extensive hypodontia. With restorative implication, more than one tooth is missing in any quadrant, requiring pre-restorative orthodontics for the future prosthesis to be placed. Increased overjet, more than 9 mm. Reverse overjet, more than 3.5 mm, with reported masticatory and speech difficulties. Defects of cleft lip and palate and other craniofacial anomalies. And in case of submerged deciduous teeth. And here you have all the points for this tutorial, and see you in the next one.
Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.